Welcome to the Fresh RN podcast. The information contained in this podcast is meant to supplement your existing knowledge and not replace it. Always refer to your state board of nursing, standards of care, and respective institutions' policies to guide your practice. All identifying patient details have been changed to protect their privacy and remain compliant with the Health Insurance Portability and Accountability Act of 1996. Thanks, nurses. Stay fresh. Elizabeth is looking at me crazy.
Well, I just took a sip of tea. Did you hear me gulp?
They're not really there, but they're there. You can't just sedate this person because you want to. Actually, Katie, you're wrong. So.
No, you're just after the money.
You see, Bugsy? Welcome to the podcast. I am Katie Cleaver.
And I'm Melissa Stafford.
And I'm Elizabeth Mills.
I am Kieran McMahon.
Thank you for joining us. Today, we wanted to talk about something. I've had a few people reach out to me just as a new nurse working in maybe ICU or not necessarily always in the ICU, but how to take care of someone who's unconscious. Taking care of a patient is, kind of straightforward when you're talking to them and you can ask them questions. And maybe even if they're not all neurologically there, you've got a back and forth. You can ask some questions to somebody, but how do you...
You're describing a couple of my coworkers.
They're not really there, but they're there.
They're just a little off.
You can ask them questions.
Not really responsive.
Did you get that email? Okay. Anyways, but how do you take care of someone who's unconscious? How do you talk to them? Do you talk to them? How do you talk to the family? Things like to consider like consents, next to kin, and how to encourage the family to be around that patient. Our experience is mainly in the critical care aspect. Let's talk about a couple assessment tips if you're assessing an unconscious patient, because the unconscious patient assessment is very different than a conscious patient, not just neuro world wise, but the way you go about that is just different.
And, I want to say also that just because their eyes are closed all the time doesn't mean that they can't respond to you. Mm-hmm. So they may have their eyes closed. They may have they may not speak to you, but they may be able to follow some commands. Mm-hmm. So don't assume because someone isn't awake and looking at you that they don't understand the things that are going on around them.
That is a really, really good point, because you can really assume a lot if you say someone's name and they don't open their eyes. But if you ask them to give me a thumbs up, show me 2 fingers, wiggle your toes, blink your eyes, or I don't know what other ones.
Well, sometimes eye movement. So if you hold their eyes open, can you look at me to your left? Look at me to your right. Maybe they can't open. I mean, truly, there's a cranial nerve that allows a patient to open their eyes. And maybe that cranial nerve is damaged for whatever reason, but they can still look side to side, up or down. Or
I've actually had that before where that nerve was damaged and the patient couldn't open their eyes, but they were there. Mm-hmm. They were not sleeping. And actually, we're talking right before we started recording this, we have all had the instance of we've had former patients come back to the unit. And, you always want to know, especially if they've been on sedation, like what do they remember and what they don't. And a lot of them, when we thought they couldn't hear us, could absolutely hear us. So it's so important to always interact with the patient like they can hear you.
Yep.
Never ever say anything in front of that patient that you wouldn't want them to hear if they were sitting straight up looking at you. And I know, when you have an unconscious patient, that's not the room you go in to complain about your coworkers or complain about this or that. I see that a lot. And that's not, who knows, maybe they can totally hear that. And if the patient was awake, would you be doing that?
Yeah, absolutely.
You said something. Tell them what that patient said to you.
Oh, we had a patient that had been in the unit for a long time and came back, and I had taken care of the patient on multiple occasions. And I'm like, "Do you remember me?" And they were like, "No, but your voice is really familiar. I really remember your voice."
Right, creepy, right?
I know. And then I was like, "Is that a good thing?"
Yeah.
Did I behave myself? Yeah. No, it's a good thing. I liked hearing your voice. So.
What's crazy is there's a lot of research now with post-ICU syndrome about post-traumatic stress disorder after being in the ICU for a prolonged period of time on a ventilator, unconscious, etc. And patients have reported, feeling like, one, they've been abducted by aliens because they're knocked out for a period of time. Then all of a sudden there's people in there pinching them, eliciting a pain response, or all of a sudden they're having a procedure done. Like, it gives people nightmares kind of thing. So there's a lot to be said for making sure you're still communicating with the patient, no matter what it seems like they may or may not be understanding.
Yeah, I mean, I don't think I have taken care of someone who was locked in too. Like, just because someone doesn't look like they know what's going on, you can't predict their awareness necessarily. So it's
or what they'll remember.
Yeah, I've definitely seen documentaries and things about patients that have been, out of it for a long time, and they remember hearing conversations over their bed about the patient, about themselves, and like wanting them to give up, and like that kind of stuff.
Mm-hmm.
So it's like, just because they look like they're asleep doesn't mean that they are, or that they can't hear and perceive what's going on around them.
So you need to talk to them like they're with it and explain to them what you're about to do. Okay, I'm going to assess you. I'm going to open your eyes. And consider, too, if they're on a lot of sedation, weaning some of that sedation down.
Mm-hmm. Have the minimal amount of sedation and pain meds that they would,
Yeah. I mean, in the ICU, I know in our neuro ICU, we use as minimal amount of sedation as possible. But in other ICUs, a wake-up holiday, sedation holiday, wake-up assessment has to be done every shift, I believe, at least. But a lot of that involves, cutting down on the medication and sedation and stuff.
Yeah, I think, that's really, really important, because you don't want them to have excess stuff, because that's just impedes healing. It's unnecessary.
Well, it prolongs, it puts the patient more at risk for ICU delirium, which is a big deal. So it's stuff like propofol and propofol is a big one right now. Precedex.
Those are the two
our
main
IV
ones.
pain medication, stuff like that. So there's a lot to be said for making sure that we are doing a good job of weaning off sedation as much as possible.
How do you communicate to family members and stuff, like to be able to talk to them like they're there? Is that difficult to get them to recognize or understand that they can possibly still hear you, or believe that they can hear you?
I mean, I always tell family members, I'm like,
Do they just accept
they may
it?
not be able to tell us they can hear us, but I tell them, talk to them like they can hear you. I mean, it let them know that you're there, one, because they need to hear familiar voices, whether or not they're with it or not. And tell them about the day, remind them of where, you're in the hospital, stuff like this is going on.
My experience has been the family is very eager to believe and want to believe that the patient is doing as well as possible. So if there's any inkling that they may be able to understand what's going on, the family is usually really wants to talk to the patient and absolutely believes it. It has been my experience. My challenge has been more the other side of they're bothering the patient too much and inhibiting their ability to rest. But what so my kind of common thing is to always talk to the patient like they know what's going on, because I personally can't. I've had patients come back and say they knew what was going on when I was like, if there was a patient that I was going to guess that had no idea what was going on, that would have been one of them. And then they come back and they know what was going on.
Yeah, and I think too, working in a neuro unit, we have a good bit of unconscious patients, and the families want to help and essentially do an assessment. Come on, Granddad, squeeze my hand, wiggle your toes, open your eyes, and they constantly do. They see us do that, so then they do the same thing, because ultimately they want to help them do that. So maybe they won't do it when the nurse is there, but they'll do it for me. They'll do it for me, and you hear it all the time. And so what I try and tell families is the same thing. Talk to them like they were sitting right beside you in the living room. Tell them about your day. Tell them about what's going on with Aunt Susie, or tell them that Christmas is coming up and these are the plans that we have. And if it's their birthday, sing them happy birthday. Let me assess the patient, because we do it all the time, so they kind of need that in between rest.
And we need to get the best out of them possible.
Yes.
So if the patient's family is exhausting them in between these neuro exams, they're not going to do as good for when the exams actually occur, because they're so fatigued.
Mm-hmm.
I mean, they need that rest. So yeah, it's so important to tell the family to talk about like casual life stuff, and I think it's, some people feel silly doing that, I think, but if you can model it as the nurse, and honestly, even when I had patients that I knew were brain dead, and that's a patient I know can't hear me, but it's still their loved one, so I'm still going to talk to them like they can hear me, and I think that means something to the family to hear. Okay, we're gonna pick up your head and flip your pillow, and it humanizes it a bit.
Yeah, and cleaning out their mouth. I'm going to brush your teeth. I don't like stinky breath. Can't have stinky breath here, so I'm going to go brush your teeth now. And kind of making it funny wherever possible, and making it more human rather than just a series of tasks that we have to do. That we have to do, because we do have to do plenty of tasks. But if you tell them why. It makes a big difference. I make jokes all the time. So one of the CNAs that I work with, I love her. Her and I kind of go back and forth all the time, just making silly little jokes. And we include the patient in it sometimes,
Would this be Tasha?
It is Tasha.
Tasha Davis, the best CNA in the world.
Seriously. Like,
she should have a podcast.
She should.
Fresh CNA. Copyright.
But, she'll tease me and I'll tease her. And, it'll be something like, Mr. Smith, you need to tell Tasha to quit picking on me, and he's appears to be completely out of it. But, it helps the family see the kinds of things that we do to interact with a patient, even though they're not necessarily interactive back, if that makes sense. So I think that's a big thing, because I agree with Elizabeth. They need to hear familiar voices. They need to feel that that their loved ones are there and supportive. And who knows how much they know and understand, but we don't know that, and because of that, we need to be very respectful of them and encourage them in any way we can. And having family members there is an important part of that.
But we do know, based on all the research that's gone on, that people do have. They may not remember specifics, but they can recall when traumatic things are done, and so trying to help reduce that as much as possible.
Is it the SCCM that has the videos on ICU delirium?
Yeah.
I'm sure, or, AACN, or there's a lot of data out there on ICU delirium, and it relates to whether or not they're in the ICU. It relates to someone who's essentially unconscious and the care that they received, and the kinds of things that they remember, and the things that we think as normal everyday things are things that are received as traumatic on their end because they don't understand what's going on.
Right.
Like hearing the alarms go off. There's accounts where patients heard the alarms and felt like they were something like, not at an airport, but some like they thought that they were somewhere else, or it was like they were caught in the middle of like a building on fire or something. They thought ambulances were out or something like that, and
something
it's like
scary.
Something, and they're like, I got to get out. It's just weird.
Oh yeah, and then they try, and then they get restrained, and then it's worse. Yeah, it's all very traumatic.
And for those patients that are pulling on things, you say, you just you treat them like they're people. They are people, and I think in an unconscious person, we tend to forget that there's a person there. We're not just doing this, getting it all done, walking out of the room
because they're intubated and sedated, and they're the easy patient.
No.
Yeah, and I think you bring up an excellent point talking about restraints. When I first of all, I hate using restraints because it's more documentation for me. But, we've all had patients that we have to restrain for one reason or another. But I tell them why I'm doing it. You've got a lot of tubes attached to you right now, and I need to make sure that you don't pull those out because you can damage your trachea. I know that you want to move around, so I'm going to let you have a little bit of room, and you can scratch your tummy or things like that. But I need you not to be able to reach up to your nose and grab this tube that's in your nose. And they may or may not understand that. But, again, the family hearing us talk to the patient like that, and hopefully hearing it over and over again, I hope when they do become more responsive, that it's not as traumatic for them long term. The sicker a patient is, the more likely they are to have kind of some traumatic type memories.
Mhm.
And the whole PTSD thing, is a very real problem. So we have to be mindful of that when we take care of a patient who's not awake.
Yeah. Yeah. And another consideration when you have a patient who's not awake is consents and next of kin and that kind of stuff. That's important, an important consideration for an unconscious patient, because if they need a central line, they can't sign their own consent.
Mm-hmm.
If they need an art line, if they need to go to surgery. So that how you figure out who the next of kin is if they don't have a power of attorney, or if it's kind of muddled water. You can use your case manager, which is a great resource. But it's important to know that you have to do that. And I think it's better, just speaking from someone who's worked with patients that have been out of it, is to immediately figure that out.
Mm-hmm.
Because the last thing you want to do is, we need a central line now. Oh wait, who's the next of kin? So figuring that stuff out when they get admitted, and hopefully you're figuring out if they have a healthcare power of attorney already, but I feel like not a ton of people do.
And know your policy in your institution.
Mm-hmm. Like what
Because they
qualifies
have-
as next of kin?
Yeah,
in
and
your
there's
area.
actually an order. So if the patient does not have a spouse, or children, or there is an order in which who would be considered next of kin.
Mm-hmm.
Where do you even go to find out where they have healthcare power of attorney at? Is that in
That's also usually established on admission somehow.
Yeah.
wristband?
Well, so if they've come in, it depends on the situation. So if they come in, let's say you were out in the street and got hit by a car and you're unconscious, but you were alone. So your family or no one you know is with you. So typically by the time you get to the emergency department, hopefully the police or someone has looked in your driver's license and figured that out and all that kind of stuff.
But in that situation, they're not going to not treat you because they don't have consent. If
Right,
it's
right, right.
emergency, if it's necessary, they're going to treat you like you would want it to be done.
Mm-hmm.
Yeah, and then in the process, figuring out who do we need to notify. But when someone's admitted to the hospital, usually someone is with them, and we can figure out through them are you the spouse? Who do you have kids? Half the time that's who's with them. Elizabeth is looking at me crazy.
Well, I just took a sip of tea. Did you hear me gulp?
Oh no, I
Oh,
didn't.
good, because I mean, it sounded to me like it made a really loud gulp noise.
Oh,
I
so I was like, is it that crazy that we like? figure out
No.
next
was
to
thinking
kin?
the same thing. I'm
Oh,
like,
am
I
I
don't know what's
wrong?
happening right now.
No,
but
I just thought it sounded really loud.
maybe she's got like some statistic that says like 85% of people are admitted alone. Or
Yeah.
something like that. We're like, wait, were we
Like,
speaking out
actually-
of turn this whole time?
Actually, Katie, you're wrong. So
No,
I'm going to have to go ahead and stop you right there because you're wrong.
but anyways,
I just gulped.
a big gulp set. See you later. So thank you for those of you that got my Dumb and Dumber reference. And so next of kin. But most people come into the hospital with somebody, and through that we can figure out, oh wait, or maybe they're already in the system and we got a healthcare power of attorney. If they're not, we
that's
can.
the benefit of having a electronic medical record.
Oh yeah.
Once we get a copy of that healthcare power of attorney, it becomes a permanent record in the chart. So, if I come in tomorrow and have a healthcare power of attorney, and then 10 years down the line, assuming I can't remember if they expire or not, but assuming that it's still in date, somebody can just pull up my medical record and find that information. But it really does. We honestly just have to point blank ask. Do you have healthcare power of attorney? And then they say no. Do you know if somebody else has healthcare power of attorney? And then if the flip side of that is, even if they say yes, we need a copy of it.
Mm-hmm.
So we can't just take somebody's word for it that they're power of attorney.
Oh, yeah.
We have to have
Because
a copy
people
of
don't
that.
tell the truth.
That's true. Unfortunately, people don't.
lie? No.
What?
Yeah, and that's kind of more common in families that have some disconnect.
Yes.
Yes,
Yes.
I am head of this estate.
No,
Well,
you're just after the money.
yes, hey, Bugsy.
Oh my goodness.
Oh lordy.
Yeah, it's the end of the day, guys. We're getting a little slap happy. But I forgot where I was going with that.
Healthcare power of attorney in the medical record.
Yeah, it's they need to provide evidence or proof. Like if they don't, they need to show us.
Oh,
Show us the paperwork.
yeah.
sweetheart.
Show me the paperwork. I'm not just gonna believe you. And it's important that one of the common things I've run into, this is what I was going to say, is I've had people think that the healthcare power of attorney just means they can make whatever decision whenever they want when the patient's not necessarily incapacitated. So let's say, well, maybe they might be to a certain degree, but if we have a patient who maybe they can't communicate that well, but they know what's up, and if we can find like a
Communication board.
Communication board, or the blinking the eyes or whatever, we need to, like, if the patient is all there mentally, but maybe they just can't communicate, like, then we need to do what the patient wants. Just because I have a healthcare power of attorney doesn't mean the healthcare power of attorney gets to do whatever they want whenever they want.
Override patient consent.
Right.
And that's really important. And the other thing about healthcare power of attorney, there's also the misconception if they have what is it called?
Durable power of attorney?
I think so.
Or like the financial one?
Yes. There's a
They're not
difference.
the
So
State of someone's.
I think it's a durable power of attorney.
Is it durable?
I think so.
We have no idea because we don't deal with it.
The important thing is you need to establish what kind of power of attorney that they have, and they have, medical power of attorney is completely different than a financial power of attorney.
Yep.
And they might be the same people, and they very well may not be. So differentiating between that is important.
One time I had a patient. He was not incapacitated, but he had surgery, so he was a little out of it, and I can't remember who it was, his healthcare power of attorney, but I can't remember that relation. But he was annoying her post-op, and she was like, "Can you just give him something to make him sleep? It's okay. I'm the healthcare power of attorney. Just knock him out." I'm like, that's not how this works. I can't just sedate this person because you want to. That's sorry, lady.
I'm the healthcare power of
Like
attorney.
a
It's
husband
fine.
and wife
Take
scenario. My wife speaks too much. Can you make her be quiet?
Can you just sedate her?
I'm responsible for their decisions.
It's okay.
Yeah.
So yeah.
This is the one time I had the chance to use a mute button.
Or silencer.
Just let me use it. Yeah.
The silencer.
Yes, my husband said something really funny I asked him randomly. I was like, "So John, do you ever wish you had a silence button for me?" And he paused. He goes, "No, I wish I had a silencer," which is different than a silence button, because with a silencer, you'd still be able to talk. It would just be quieter. I was like, that's fair. I'm kind of loud. Kieran adjusts my volume down. He literally just did that.
He did it again.
And he did it again.
You're still too loud. Just kidding.
Sorry, guys. I'm sorry. So consent is really important because it's just helpful to be proactive about that. So when you need to get the central line, when you need to get the art line, you're not figuring that out later. And also knowing that, hey, getting the consent on the unconscious patient isn't going to be as quick as the conscious patient, right? You're going to have to consider that.
Even the patient even if they're still conscious, but they're confused, you still have to.
Yeah, so that kind of stuff is to consider that in your kind of time management, So yeah. Do you guys have any other points on tips for talking to and dealing with an unconscious patient?
And just also, letting know when you are assessing, when you're doing a neuro assessment on an unconscious patient, letting the family know what you're doing. Just say, hey, if they're not able to follow commands, I have to do these painful stimulations to see what kind of reflexes they have. Because, some people will think, why are you pinching John Doe?
Yeah.
Yeah.
Why
are these? Yeah.
What are these bruises from?
Yeah.
Oh, no, that's real.
Yeah, and it's like, well, we kind of, yeah. So, I think that's important to educate the family about the assessments. That's really helpful because, you can use that as an opportunity to say, we need to maximize what they can do during these assessments. So don't rile them up in between or hang out with them, but don't try and make them perform, because they'll do that a lot. Because I think one of the things that they want to do is they want the loved one who is unconscious to do the most they can.
Yeah.
And it's this natural thing where you want to see them squeeze their hand. You want to see them do this and do that. So you just sit and you try till they'll do it. Yeah. When really that's exhausting to the patient. They just can't tell.
And sometimes it makes them mad if they're aware of it.
Oh, yeah.
So they just won't do it anymore. like if I don't move, you'll go away.
I've seen that too. Yes,
Yeah.
I've had patients like who are not really able to communicate, but super annoyed with the family that won't stop bugging them. Like you can like see just this big change when the family leaves.
Yeah.
And just a way that they can kind of or you can tell when like it's just the furrow of their brow, or they're like they just look frustrated.
Changes in blood pressure and
Yeah.
heart rate, and then some of those things also change too. So
Leave Mima alone.
I'm in the hospital to try and get some rest and relaxation.
Which is
okay?
not
Okay.
gonna happen.
yeah, that's
Sorry
a
about that.
misconception.
Yeah, we don't get arrested, unfortunately. Okay, any other tips for unconscious patient care?
I don't think so.
All right, guys. Well, thank you guys for listening. Please make sure you go to freshrn.com/podcast to find show notes and all of our other episodes. If you like our podcast and want to show us some support, the best way you can do that is write a review for us. We really, really appreciate it. It goes a long way. And make sure you subscribe and tell all your nurse buds. We'd really appreciate it. So thanks, nurses. Stay fresh.
Damn girl, better hit the floor. All the other fellas better run for the door. Stop, drop, and roll with me. I got the heat that'll make you scream.
We are cruising right along.